I believe I do have some of my pre-recorded like salivary didactics on YouTube, etc. So I was hoping to sort of refer you guys back to that and then work on some of the more of the unknown types of cases today. I think this presentation has both some kind of classic bread and butter things as well as some variations and some kind of important, kind of high grade, distincty things. So hopefully you had at least maybe some chance to look through the slides. If not, no worries. We will just sort of describe as we go. And looks like there are enough of you on that I'm gonna see if someone wants to talk about number one.
I mean, I can describe it just for the sake of getting things started.
Mm-hmm.
So low power, you have these very well defined and lobulated groups of salivary gland. These don't appear to be neoplastic on first glance. They have a normal regular configuration. But what's interesting is that there's a lot of inflammation.
Mm-hmm.
What also catches your eye at high power is this sort of like the degenerated, torn away section in the center, which and Abraham says in chat, yes, there's a lot of fibrosis. I do agree that the septations between the normal lobules are very prominent, but there's sort of basically necrotic debris in the center of the field. And as I'm sort of following along, I'm looking for things like squamous metaplasia and let's say focally there's a little bit of like trying to be dystrophic calcification. So I'm not convinced we're dealing with a neoplastic process here, given the background of inflammation. You'd think about, what's the word? Like sialadenitis or necrotizing salometaplasia, that sort of thing.
Mm-hmm. Cool. Yeah. So we don't see this particular thing resected very often. So I thought it was just a nice example of a combination of two things. One, very, very abundant sort of sialadenitis with these small foci here that you may appreciate are both in the smaller ducts, as well as this very large thing that's in a large duct, which is a
sialolithiasis.
Exactly, it's a sialolith. It's a stone. So, sialadenitis and sialolithiasis. Gosh, I can't pronounce it this morning. Go hand in hand. When you have a nidus that starts to calcify, and block a duct, you get surrounding inflammation and fibrosis, etc. So sometimes they do sort of lithotripsy of these. More often than not, they either sort of wait for them to resolve or kind of milk them out of the duct system. And very, very rarely we actually get a whole gland resected for it. So just a nice example to remember that this is a very common problem. But we don't necessarily always see it because it's more medically managed. And if we do see it, sometimes they're just these little gross only, stones. Okay, that was hopefully not too challenging of a one. Okay, awesome. Yep, stones. So the next one.
I'll go ahead.
Thank you.
It's well circumscribed. So that's kind of, I guess, like a tip off. Maybe this is not something that's carcinoma. And it's very blue on low power. Not, so maybe we're not thinking of, say, like a Warthin's tumor, because that would be more oncocytic. And then there's a lot of these like cystic areas, like there, yeah, maybe just fill with some amorphous pink material. I guess like the cells themselves look fairly monomorphic. I don't think I really saw two different populations. And I guess like the background is sort of like mixoid, but not, I guess like I'm not really PA was something that like potentially was something I thought of, and I was like, but it doesn't really look like it's made of multiple elements. It just kind of looks like it's, got this matrix and then this one type of cell. But maybe it still is a PA, or maybe I was thinking like myopithelioma potentially. Yeah, that's sort of where I was at with this case.
Okay, so I definitely agree that, the circumscription of salivary gland tumors is always very important as a starting point. So, is it circumscribed or not? And, you can have low-grade carcinomas that are circumscribed, and you can have benign things that are circumscribed, but generally you're not going to have a high-grade malignant thing that's circumscribed generally, right? So that's a good indicator. Very cellular with a combination of kind of collagenous and myxoid stroma. But one thing I will argue is that, sometimes when we talk about 1 versus 2 cell types, it's not necessarily always that there's a drastic shift in morphology of the 2 cell types, but more of, is there an architectural separation of the 2 cell types? And so, one might argue in a purely myoepithelial tumor, you really shouldn't see ducts, because ducts are formed by epithelial cells, often with a combination of myoepithelial cells at the abluminal kind of area, right? So I would argue that perhaps you might be appreciating these more epithelial pink ducts surrounded by these other cells, which you might regard not necessarily as super morphologically different, but as architecturally different in their placement, in their geography around these ducts. So does that color your final thoughts then?
Yeah, then I'd be more thinking of a PA.
Yeah. Exactly. So, pleomorphic adenomas don't always have to have the cartilage, right? But they can have this sort of vague myxoid or myxochondroid stroma that I think is also a good clue. They can be extremely cellular, as in this case, right? Sometimes PAs are very paucicellular, especially if they're very chondroid rich. But yeah, this is just a nice example of a kind of a cellular pleomorphic adenoma. People have asked me in the past, like, okay, when do you call something a cellular PA versus just a PA? Well, there's not really a good definition in any of the literature, but you could call it a cellular PA if you're concerned that, other pathologists might look at it and think it's, I don't know, something else, more like, yes, I see that as very cellular, but I also see bilayered ducts in this myxoid chondroid matrix, and there are no other features that might suggest a different biphasic salivary tumor. And so we'll see a couple other biphasic salivary tumors in this PowerPoint, or in this presentation. But, remember, circumscription and number of cell types is always sort of the way that I like to start. And so as we look through this one, what are the 2 stains that those of you who've signed out with me, what do we often use to highlight the 2 morphologic cell types, whether it be PA or other?
Like c-KIT and P40.
Yeah, exactly. So yep, exactly. So CD117 or c-KIT tends to highlight the epithelial component, not only of adenoid cystic, right, but also of things like pleomorphic adenoma, basal cell adenoma, and P40 highlights the myoepithelial cell population in pleomorphic adenoma, basal cell neoplasms, adenoid cystic, all of the above. So the presence of c-KIT/P40 is not definitively diagnostic of a specific tumor type, right? But it's diagnostic of how many cell types are present. And arguably, you can see even in this second example, these smaller myoepithelial cells around these more plump duct-like cells. Okay, so I kind of gave away the answer here, but did anybody see anything unique or different in this tumor that might be worthy of mention?
Like I could try.
Yeah.
Like in the middle, there is kind of like nodule, hyalinized nodule.
Okay.
And here the ducts or ductules are like the cells are more, they reveal more nuclear pleomorphism. They are enlarged. I'm able to see prominent nucleoli, even like without higher magnification.
Mhm.
I believe it's invasive. It's not like well circumscribed comparable to the prior slides, like prior one. I'm trying to see if we have benign PA here, because like those, for me, they are not benign.
Okay.
So maybe here, no, this is, I believe, malignant, those ducts, but I'm trying to see if there is like benign PA component. Maybe I consider this in the middle, the hyalinization, the nodule, like I
Okay.
consider it maybe like that, this hypocellular hyalinized nodule, maybe this is XPA.
Mhm.
So I was thinking about carcinoma of XPA.
Okay. Thank
Like,
you.
that's
Go
what
ahead.
came to my mind.
Yeah. So thank you. Those are some good observations regarding the cytomorphology of those cells. Does anybody agree or disagree with the final conclusion here?
Yeah, even I thought it's carcinoma, explomorphic adenoma, maybe salivary duct carcinoma.
Mhm.
Yeah.
And I guess my question for you both is, what component do you think is invasive?
The epithelial.
Epithelial. Yeah.
Okay, and all right. So I'm going to go back to that epithelial area that I think we saw that looked,
Like it's either invasive or at least like in situ.
okay,
This is the impression that I got. So maybe we
Mhm.
need stains
okay,
like to highlight the myoepithelial component.
okay.
So I prefer to do P40 or like SMA or any myoepithelial marker.
Okay. And on this H, that's a good idea to see if these atypical epithelial cells are still confined within ducts or escaping the ducts. Do you see a myoepithelial cell layer even on H&E in this field?
Yes, I do.
Yes, right. I agree.
Mhm.
So in these areas where there are atypical epithelial cells that have enlarged nuclei with prominent nucleoli, definitely those are atypical findings for a pleomorphic adenoma. Usually pleomorphic adenoma nuclei are small and nice and vesicular chromatin without prominent nucleoli, without numerous mitoses. But once you start seeing these changes, yes, that's definitely worrisome. However, I think in most of these areas, those cells are still confined by a myoepithelial cell layer. So I'm going to go down to some of these areas that we were looking at before. I think there was even like a nice, there it is, a mitotic figure right within that duct. So also abnormal, but at the edge of all of these nests, I see this flattened layer of myoepithelial cells, which perhaps raises two possibilities. One, that this is an in situ type of process arising within the duct system of a pleomorphic adenoma, or this is an invasive process that is defined by an invasive tumor that has two cell types coming out of a pleomorphic adenoma, right? So it's either invasive carcinoma x pleomorphic adenoma of a tumor that has two cell types. So what are the invasive carcinomas that have two cell types? First of all, what are our options?
Epithelial, myoepithelial.
Okay, epithelial, myoepithelial carcinoma, and
Adenoid cystic.
adenoid cystic,
Adenoid cystic.
exactly. So do these look like either epithelial, myoepithelial, or adenoid cystic necessarily?
No.
There is some cribriforming. I can talk now finally.
Okay.
There's some cribriforming, but no, not really.
Yeah, so we'll see. I mean, we'll see examples of both of those in a bit. But yeah, this doesn't look like it has the nice kind of cribriforming or bluish mucin like adenoid cystic. Adenoid cystic should not have these beautiful like large nuclei with nucleoli. Usually they're more wrinkled. And epimyoep tends to actually have more of a clear, very prominent myoepithelial cell layer. And in here, the myoepithelial cell layer still looks small and perhaps non-neoplastic. So my conclusion, I bet you're guessing what my conclusion was, is that I did not believe this was invasive. I believe that these epithelial abnormal islands we're generally always confined within a basement membrane. And so there are ways to slash myoepithelial cell layer within the larger confines of this relatively circumscribed pleomorphic adenoma that, yes, does have some stromal central hyalinized sclerosis. So there are two ways to think about carcinoma, well, three ways to think about carcinoma X pleomorphic adenoma. One is just purely invasive carcinoma X, where there's a pre-existing benign PA and then invasive carcinoma kind of surrounding it. There's in situ carcinoma, which might be an option for this case, in which the atypical, slash potentially malignant cells are confined by a myoep slash basement membrane layer. And then there's intracapsular carcinoma, in which perhaps the malignant cells have escaped escaped the basement membrane, but have started to infiltrate, but not escape the sort of confines of the larger PA slash capsule. So there are these three ways to think about carcinoma X, which is sort of totally invasive, burst beyond the myoepithelial layer and beyond the capsule. In situ, which is sort of confined to the myoepithelial layer, and intracapsular, which perhaps has escaped the myoepithelial layer, but not the larger capsule of the pleomorphic adenoma. Now, whether or not we see this happen in real life is another question. This, to me, is probably atypical or in situ, because I don't think these cells have escaped the basement membrane layer. So in theory, this is how it starts, right? This is how carcinoma X starts, with essentially purely, cytologic atypia and mitoses and prominent nucleoli within the confines, and then it starts to escape and invade. Does that all make sense? Do you agree with me? If you don't, that's fine. There's a lot of differential sort of diagnosis possibilities in salivary, but this is how I came to the conclusion of this case. In contrast to, we're just going to move down the road, next one.
So I guess I'll speak again. We have a sort of a variably cellular lesion with this sort of hyalinized, almost looks infarcted area that you pointed out with dystrophic calcifications. Cytomorphology, it's hard for me to do much with there, but the piece on the right-hand side, that's a lot more richly cellular, which I guess you want me to focus on the more the more basaloid and maybe less mucinous components over here.
Oh, I can go over here. Where do you want me to go?
I was gonna say the the whole other piece on the right-hand side.
Okay.
Yeah. So if you kind of look closer at the cytomorphology here, and you see that you're still kind of forming these glands and ducts, and what the ducts are filled with is the sort of bubbly, lightly staining stuff. I think that's a mucin production, and so I'm leaning towards this being like a mucoep.
All right, we have a vote for mucoep. We have a vote in the comment for epimyoep. Anybody else?
I'll admit some of the cells do have some clearing out, which is a feature that I often like with the myoepithelial component, but
Epithelial, myoepithelial. All right, so another vote for EMC. All right. Whoa. Sorry, did I cut somebody off?
For EMC, wouldn't you want to see sort of nice stacking of, ideally at least?
Ideally, at least you would. Tell us what you mean by stacking. I think I know, but spell it out.
With the sort of big puffy cleared out myoeps on the outside that can sort of envelop then the little epithelials on the inside. I mean, I know that you can get overgrowth of the myoeps on the outside, so all you're seeing are these sort of clearer cells. But
Right.
I guess I thought, like, ideally anyway, you'd sort of want to see like a two-tiered, configuration.
Yeah, no, I agree with you. So I think I think what the point here is one, we're all seeing something that is highly cellular that appears to have probably some kind of invasive growth pattern in terms of these multiple lobules. Two, that has cells that have perhaps in areas kind of small wrinkled nuclei with perhaps some cleared cytoplasm, and in areas pointed out some of this myxoid material that I think we have to distinguish. Is this intraepithelial mucin or connective tissue stromal mucin, which may differentiate from mucoep versus a myoepithelial rich lesion, right? Something that has intraepithelial mucin should be considered a true mucocyte, such as in mucoep or in mucinous metaplasia. But bluish stromal or connective tissue mucin is generally produced by myoepithelial cells. So you would not regard this. I think this is not intraepithelial mucin. As I think most of you probably think that these are probably myoeps with clear cytoplasm and stromal mucin. I agree with you there. And as Perry was saying, for epimyoep, I don't really see that there is a punctuation by true ducts, right? So since epimyoep is a biphasic neoplasm, you want to have true ducts. And so you could throw a C-kit on here and see if any of these little lumina are actually surrounded by epithelial cells, which they may very well be, or they could just be pseudocystic spaces that are actually lined by myoepithelial cells that are producing this stromal, bluish connective tissue mucin. So that's thing one. That's a subtle difference that may or may not, change any prognosis in this patient. So, but from what I understand, the differential, which I think is a good one here, is an epithelial myoepithelial carcinoma versus a purely myoepithelial carcinoma, right? And so the presence of those ducts is going to be the only thing that differentiates epimyoep from just myoep. I think you all excellently noted that this is a carcinoma. I don't think any of you yet, well, except for one, perhaps vote for myoepithelioma. I haven't heard so many people calling this benign, which I think is the right answer. I do not think this is benign, but perhaps as noted in the first section, we can perhaps guesstimate where this may have arisen from. So in the center was this hyalinized burnt out nodule with stromal calx that maybe has some almost duct-like structures. So if I were to venture that this is a true carcinoma XPA, would you buy it?
Sure.
Yeah.
Sure. So I think that if the few things that are going to be helpful in this case for that, right, is there a P40 positive myoepithelial layer in these smaller ducts in the hyalinized rich area, and or is there any epithelial layer in the invasive area, right? So that's going to help you decide, one, that this coming out of a PA, two, whether this is epimyoep or just myoep. I don't remember ever finding any true ducts in this case, so we called it myoep. But the thing that is similar about both myoep and epimyoep, whether they arise from a PA or not, is the fact that they tend to have these sort of large zones of very cellular tumor that are almost lobulated. And then in the center of these lobulated zones is sometimes this degenerative or even necrotic area. So even despite the fact that these are cytomorphologically not always extraordinarily high grade, I mean, I don't see tons of pleomorphism or mitoses, these can actually behave very aggressively. So it's important to realize this morphologic overall like characteristic geographic pattern, and not call this benign, because these are malignant, these are carcinomas, and they can have behaviors that are a little bit outside of what we might expect for such low grade bland cytology. Remember that carcinoma XPA can be of any subtype, myoep, epimyoep, salivary duct. you know, et cetera, mucoep, et cetera, et cetera. One of the more common ones we see are myoep and salivary duct. So just keeping that all in mind. You guys have comments or questions, or is that clear? I might jump to this one now just for comparison, which was essentially the last case. And I think this may highlight the features that we were just perhaps describing. Does anyone think this is benign or malignant?
Oh, this looks malignant.
Yeah.
Yeah.
I think just based on these tongues, right? These tongues that are percolating into the normal, definitely malignant. Similar features are these small cells with very, very clear cytoplasm. So again, whenever you see clear cytoplasm in a salivary type tumor, you want to perhaps consider, could they be myoepithelial cells? And yes, this is exactly. So what's different about this case is that here we actually do have some of these geographic populations of ducts where you have a central, I'm just drawing a line through it, right? A central kind of luminal myoepithelial layer, and then an abluminal, what did I say? A luminal epithelial layer and an abluminal myoepithelial layer where you have these cells lining up very nicely, exactly stacking. So those are the subtle features to me that differentiate something purely myoepithelial from something epithelial myoepithelial, is this stacked or bilayered geographic arrangement of these ducts. And again, you know, this is a subtle finding, but it's diagnostic of either of these two entities. And so epimyoep and pure myoep can be very, very similar in regards to the overgrowth of clear myoepithelial cells. But this is an example of an epimyoep in my opinion. The other tumor that one might consider, you guys mentioned it already, but what's our other very common biphasic salivary carcinoma? Adenoid cystic. And so this does not appear to have the very wrinkled dark nuclei of an adenoid cystic or the cribiform architecture, et cetera. So this to me is epimyoep rather than adenoid cystic. I know we're jumping around here, but should we look at the adenoid cystic? Which one was it?
Slide 6.
Yeah. Yeah, so, you know, characteristically, the nuclei of adenoid cystic are smaller and darker, right, rather than very open, and usually don't have clear cytoplasm, even though this is, you know, myoepithelial and epithelial cells. The myoeps and adenoid cystic do not tend to have that clear cytoplasm. They tend to have somewhat kind of scant cytoplasm and very wrinkly nuclei. And the stromal material that you see here, the bluish mucinous myxoid stroma, is secreted by the myoepithelial cells. And so depending on whether the myoepithelial cells are, you know, kind of adjacent to the stroma here or adjacent to the stroma here, they're secreting this bluish mucin, right, both into the center of these nests and out at the periphery of these nests, because they are essentially sandwiching the epithelial cells. So, you know, if this is a nest of epithelial cells here and here, they tend to have more of a duct-like picture with kind of this eosinophilic stuff in the middle, as opposed to, right, the myoepithelial cells, which are at the periphery out here, right, out here, and are secreting the mucin here and here and here. Does that all make sense?
Yes.
Okay. I think adenoid cystic, when it's obvious, is probably one of the easier to diagnose. The problem is when the features don't all line up correctly. But I've provided you with a pretty clear example, I think, of adenoid cystic in terms of the combined tubular and cribiform architecture that truly is, back to back. We don't really see much solid growth here, but whenever you start to see solid growth, that would be an indicator. Maybe here's a little bit, not even, an indicator of potentially more aggressive behavior. Other comments on this guy?
I remember, I think reading somewhere that like the lumina and adenoid cystic are pseudolumina because they're all really connected, or something like those deposits are all really like part of a single connected entity. Am I making this up, or does that have some sort of
I don't think you're making it up. Like, I don't think they actually, they don't communicate with a duct system, or they don't sort of, so I guess in that regard, they're dead end. They're sort of either dead ends in and of themselves, or they just communicate with each other in like a three-dimensional, like tubular system. Is that what you're trying to say?
Probably, yes.
Yeah.
I just remember, the word like pseudolumina, and I didn't quite understand what that meant. So I guess that makes sense.
Yeah, I think it maybe means that they're not, I don't know, they're not open to the outside world, and or they're not really the quote unquote lumina of an adenoid cystic aren't really sort of secreting anything into them, perhaps. Like, so, this is an area, right, that is composed of epithelial cells, but they're not really making any product that they're secreting into this quote unquote lumen. They're just there, and you can highlight them on c-kit immunostains, and you can find that they're different from the myoep layer. So in that regard, perhaps is what they're trying to say.
Yeah, that seems reasonable.
Okay. All right. And then I'm going to go back up to this guy. All right. So somebody maybe who hasn't spoken yet.
I can try this one.
Thank you.
Okay, so the periphery looks like the normal salivary tissue, and it's predominantly mucinous glands, so it might be like sublingual or maybe minor salivary glands.
Mhm.
Then when we go to the tumor, it seems that it is infiltrating into the normal salivary gland at this
Mhm.
focus.
Mhm.
The rest of it seems pretty well circumscribed otherwise, except for this focus. And then as for the tumor, the cells are arranged in like solid and somewhat tubular and cribriform arrangement,
Mhm.
with intervening hyalinized to somewhat myxoid stroma. The nuclei or the cells, they appear monomorphic more or less, with somewhat irregular or angulated kind of nuclei,
Mhm.
and vesicular nuclei again. I think I saw perineural invasion in this. I'm not sure where, yeah, we can see it here also, yeah. So based on this morphology, I think this is like looks definitely a carcinoma.
Mhm.
So my differentials were like either adenoid cystic, maybe more solid adenoid cystic, or polymorphous adenocarcinoma.
Mhm.
So those were the differentials which I thought of, and there are mitotic figures in this as well. So
Mhm.
I think we can differentiate between the two just by doing P40 also, because
Yeah.
adenoid cystic is biphasic and polymorphous is not.
Mhm.
So yeah, that's what I thought about this case.
Awesome. Yeah. So no, that's very good. And so the morphology and architecture of adenoid cystic and polymorphous adenocarcinoma can be overlapping, where you can sort of get these cribiform, tubular, or solid areas. But one, in this case, the nuclei are a little bit more open with kind of more vesicular chromatin. If you look carefully at some of these smaller, almost duct-like structures, this to me is a very good clue on H&E of whether or not you see a peripheral myoepithelial cell layer or not in these smaller ducts. And so I in fact do not, right? I do not see a very clear myoepithelial layer bounding these smaller ducts. And so I'm already perhaps biased in thinking that this could be a monophasic neoplasm as opposed to a biphasic neoplasm, in that case, polymorphous. But absolutely, doing a P40 is going to be the most helpful thing that you can do. What's the problem? Can you use P63 in the same way? And if so, or if not, why?
I think P63 can be non-specifically positive in polymorphous adeno as well.
Right.
So that might not be helpful.
Exactly. So polymorphous can have P63 kind of patchy positivity in no particular distribution, but should be essentially negative for P40. And so if you throw a P40 on here and you see an absence, right, of that myoepithelial cell layer in an otherwise, differential diagnostic situation such as this, you can absolutely, make a diagnosis of polymorphous, which is what this is. And so just like adenoid cystic, it has very frequently perineural invasion. It has, tubular nested and cribiform type of growth. And, but yes, doesn't have the wrinkled dark nuclei, and generally is considered, as mentioned, not ACC higher grade. Generally adenoid cystic is biologically a much higher grade neoplasm, where it is highly infiltrative, highly attached to the cranial nerves, tends to recur. Polymorphous, even though it has perineural invasion, generally doesn't stick around as much and recur as much and metastasize as much. So that being said, polymorphous is no longer polymorphous low grade, right? It's polymorphous comma low grade or polymorphous comma high grade, because we now realize that not all of these are actually biologically low. And so things that might suggest higher grade behavior in a polymorphous adenocarcinoma are going to be things like necrosis, right? So this case actually has necrotic foci, as I'm pointing out, with ghost tumor cells. It actually had a number of mitotic figures. So this might be a case that is not perfectly polymorphous low grade, is perfectly polymorphous, but you may want to regard some potentially more aggressive behavior because of the necrosis and the increased mitoses, and maybe not consider this an overtly low grade tumor. So just a caveat with grading of salivary tumors, whenever you start to see increased mitoses, especially necrosis and, lymphovascular invasion, which I don't see in this case, you may want to raise the possibility of higher grade. Does that all make sense? Grading systems in salivary tumors don't always, there's no great clean grading system that spans salivary tumors, but the things I like to always keep in mind are necrosis, always bad, increased mitoses, generally bad, PNI, and LVI, also generally bad. So the one exception is polymorphous low grades, can have PNI and still be low grade. That's sort of one of the exceptions to the rule, but otherwise those features, necrosis, mitoses, PNI, LVI, generally would put something in a higher grade category. Questions? Okay. All right. How about this guy?
I can try.
Thanks.
So this looks like very infiltrative, kind of malignant neoplasm, and predominantly composed of these tubules and cysts. And there are those three types of cells. I saw mucus cells, then squamous cells, and intermediate cells. And the background stroma is quite sclerotic and desmoplastic. And I don't think so I saw any, those look like mucus cells and squamoid cells. So I thought of mucoepidermal carcinoma.
Okay. Okay, so let's sort of back up a little bit. So one, I think when we talk about invasion in salivary gland tumors, we have to always remember that there can be deposition or production of stromal material by the tumor. So I'm not saying that this isn't malignant. I think eventually this is malignant, but I would almost caution a little bit of use of the term invasive, where this central material may be intratumoral collagen deposition. So you want to look for, one, the presence of any entrapped non-neoplastic units within the center of the tumor, or the infiltration at the edge, which I do think that there's this very close approximation of the tumor to the epithelium. So yes, I do think that this is invasive, at least at the periphery, but that would be the one sort of, thing I would say about invasion. Two, Reham, intraluminal secretion in the center here with this sort of hobnail growth pattern. And one point to make is, when we speak of secretion and mucin and something that's being produced by the cells, we want to make the distinction between, is there true intracellular or intracytoplasmic mucin, or are they foamy vacuoles, or are they intraluminal secretion or intraluminal mucin? Because only the presence of intracytoplasmic mucin is going to push us more in a mucoep direction. And so unfortunately, I don't have a mucin or a PAS stain on this exact case, but if you're looking for this to be intracellular mucin, and you do a mucicarmine or a PAS diastase on this case, one will actually find that this is not staining, right? So these little vacuoles in the cells are actually not true mucin, but some other watery kind of secretory material. But I think that secretion and mucin can be very challenging to differentiate, especially on H&E if you don't have those stains. Thing two, so mucin versus absence of mucin for mucoep. And then what else might differentiate mucoep from what this ultimately ends up being, which I think people have already put in the comments. Okay, S100.
I mean, the molecular would also help, I suppose.
Yeah.
Mammoglobin.
Mammoglobin would help. Okay, so, all right, so mucoep is going to have true intracellular mucin, right? Is going to have what immunomarker is diffusely generally positive in mucoeps that highlight the intermediate and the squamoid cells?
P40 and P60. Yeah.
Exactly. Like a squamous or a myoepithelial marker. So both P40 and P63, because these are even the intermediate cells are kind of almost primitive squamoid. So both the squamoid and the intermediate cells have P40, P63, whereas the mucocytes have the intracellular mucin. All right, and then already mentioned in the comment for secretory is going to be what's P40, P63 going to do in secretory?
It's negative.
It's negative, exactly. These do not show any basaloid or squamoid differentiation. So right away, mucin and P40, P63 are going to be helpful, with the addition, as mentioned already, of S100 mammoglobin, generally strongly positive in contrast, right? Whereas in mucoep, you're not really going to have any, you may have some patchy staining for S100 or some patchy staining for mammoglobin, But in the context of positive P40, P63, you should be able to make the difference. But yeah, I mean, I think that's those differentials. Oh, yeah, molecular, as you said. So what's gonna, if you don't have immediate access to molecular, hopefully the immunos can at least point you in the right direction. And what molecular anomaly are you going to be looking for?
ATV6, like NTRK versus mammal cricket or whatever the
ARPC,
the one
exactly, exactly. So ETV6, NTRK3 in this, which is secretory, and mammal2 with either CRTC1 or 3 in mucoep. And so we do sometimes resort to those when we are challenged. But in a number of cases, you can make the diagnosis based on immunos and morphology. But yeah, the secretory, you know, has this intraluminal, it's like milk, right? I mean, it used to be called mammary analog. Now it's not, now it's no longer mammary analog. It's just secretory or secretory or secretory or however you want to pronounce it. But yeah, this is milky secretion rather than true mucin. And it has this monomorphic kind of bland cell type with ovoid to round nuclei. You can have a number of different morphologies, including kind of papillary or micropapillary, including hobnail, including tubular. You can have intracytoplasmic vacuoles that are like the pre-secretory material, or you can have intraluminal secretion. So the morphology can be a little bit heterogeneous. So always have like an index of suspicion for maybe doing an S100 and a mammoglobin if something looks a little bit unusual. Okay. Comments or questions on that one? Maybe we can skip to this guy right now, since this might be a nice direct contrast to what we just saw. So
Yeah, these are mucus cells.
yeah, exactly. And so it's interesting because if you look, if you look at the intermediate cell population of mucoep, like it actually, I agree with you, like these intermediate cells kind of look very similar to those nondescript kind of bland cells of the secretory. But I think what's prominent here are these nice interspersed true mucocytes that have an intracellular mucin and kind of peripherally located small kind of wrinkly nuclei that are in contrast to the more open nuclei of either the intermediate cells or the open nuclei of the secretory cells. So, this is an example of a actual intracytoplasmic mucin producing tumor, which is mucoep and will be highlighted. PASD or mucicarmine will highlight these. P40, P63 will highlight these. And what do we want to take note about this mucoep though?
Necrosis.
Yeah.
nasty looking.
Yeah. So one may not always be so lucky in salivary gland tumors to have a nice low-grade component adjacent to a nice high-grade component. When you do, you are able to make this diagnosis. But if you were to for example, if you were to just look at a nest like this, you'd say, oh, these are large with prominent nucleoli. There's apoptoses and mitoses, and there's central necrosis. Like me, just looking at this, there's no way I could say, oh yeah, this is a high-grade mucoep. I'm really only able to do that by finding these more low-grade cystic areas and the intracellular mucin. And I think, so these two slides here are both from the same case where, in one area you have a very nice low-grade component, and in the other area, you maybe don't. And all you have is this necrotic high-grade looking tumor. So I guess the point of these last few high-grade cases is, one, always important to look for these high-grade features to determine the biologic behavior of the tumor. And when you see high-grade features, your diagnosis of where the high-grade features came from may be challenging, because many high-grade tumors of salivary origin kind of look the same. they just look like these sheets of cells with prominent nucleoli and mitoses and necrosis. And only by seeing a low grade component would you be able to make this distinction. So would you consider intraductal carcinoma? Do you mean intraductal or salivary duct? Because intraductal carcinoma is a low grade tumor that is bounded, where these nests are bounded by a P40 positive, P63 positive, SMA positive myoepithelial cell layer, and really are not invasive.
Okay.
Whereas
I just think the morphology, you know, when I was looking, because to me it seemed like how you said there's low grade and high grade, and then the central necrosis, I was like, holy crap, is this, oh, sorry, there's kids in this room, sorry. Never mind, there's interest kids and I'm saying bad words. Anyways, you know, I looked at the central necrosis and I was thinking like, this looks like invasive ductal carcinoma a little bit, you know, so that's kind of how it got me to thinking. But I, you know, I do understand that there's low grade and high grade, but it did enter my mind. That's why I'm asking.
Got it. Yeah. So I think there's an important distinction to be made between, no, that's cool, between intraductal carcinoma, salivary duct carcinoma, and high-grade carcinoma of salivary origin with necrosis. And so do I have, where are my salivary duct? Yoga here. So I'm just showing you this in contrast, where you have islands, right? You have islands with central necrosis. What's different about the islands here with central necrosis is that the cells surrounding are not solid, right? They have these kind of, Mark Lingen calls them Roman bridging, right? Or otherwise we might call them cribiforming. But yeah, this punched hole pattern is very characteristic of quote unquote salivary duct carcinoma.
Okay.
And so these in salivary duct, they tend to have sort of an almost apocrine appearance, with kind of abundant pink cytoplasm and really smack you nucleoli, right? Versus this high grade mucoep, in which the cells at the periphery don't really create that Roman bridging structure, but they do have central necrosis. All of these are invasive, and all of the invasion, even in these large nests, can be demonstrated by essentially the absence of a P40, P63 SMA positive myoepithelial layer at the periphery. In salivary duct carcinoma, which is what we're looking at, you can have areas that are truly intraductal, where you can highlight that outer layer, but that's usually a minor component of the tumor, whether that be an in situ component or whether that be sort of pagetoid spread up the duct is, debatable. But for the vast majority of cases, salivary duct carcinomas are infiltrative and high grade. And exactly, it looks like high grade DCIS. So one of the buzz ways of noticing and identifying correctly salivary duct carcinoma of salivary gland is to actually kind of put in your brain, it kind of looks like high grade cribriform, DCIS with central necrosis. But unlike DCIS, this is all invasive. This is all just broad-based lobulated invasion. And in cases over here, you even have small nested invasion within a desmoplastic stroma. So somebody had mentioned androgen receptor earlier. I would argue that there are some cases of high-grade salivary carcinomas that are androgen receptor and HER2 positive, but mostly androgen receptor and HER2 are restricted to this, right, which is salivary duct. Important to determine the status of these tumors because they can use androgen blockade or Herceptin to treat these. So that is one of the stains we often do get asked to order, is androgen receptor and HER2, because they are targetable. And they are present in very rare examples of high-grade non-salivary duct cancer. So we do the stains. More often than not, they're negative, especially if it's not salivary duct, but it's sort of grasping at straws to treat these patients. Does that all make sense? All right, do you guys have comments or questions? I can go over the last few that I think we missed. Or we can do those another time. It's up to you.
Let's do it.
All right, we got that, we got that. Did we get this? No.
Recall the high power features are very, very helpful here. If this is the one I'm thinking. Oh wait, no, this is not the one I'm thinking of. Psych, never mind.
I think I rearranged like one or two of the slides, but from the preview, but yeah.
Maybe this is a mucoepidermoid carcinoma, right?
It looks, yeah, there's necrosis. Maybe this is muco up.
So
No?
most important point, high-grade carcinoma. Yes, check. I think we've got that. We've got that down. So, you know, again, high-grade carcinoma is high-grade carcinoma is high-grade carcinoma. And if you see, or if you do not see a pre-existing low-grade component, one that's potentially okay, because they're going to treat this as a high-grade carcinoma regardless. Two, you may or may not see a low-grade component on histology. Three, they're generally going to do molecular, so you may identify a diagnostic mutation in the end, but always look around for a lower grade component to see if you can identify the origins. I'm helping you out here. Anybody have any thoughts?
A cynic cell, maybe?
Yeah.
Yeah, so this
Go
might
for
be,
cynic.
yeah, cynic cell carcinoma, I guess.
Yep. So you have these nice little acinar, tightly packed acinar structures, which in areas you may appreciate this vague kind of very stippled purple cytoplasmic material, which are the zymogen granules. But you know, otherwise, this is a high grade carcinoma. You look over here, you're like, I don't know, I can't tell where that came from. So, you know, that's the theme of these last slides. If you look hard, you can find where it comes from. And I've given you an example of a nice lower grade kind of circumscribed actinic cell carcinoma that has these nice purple zymogen granules. And what's the one stain we do use to highlight those zymogen granules?
Amylase. Oh,
Yeah, that's a good
yeah.
talking point. PAS definitely, but wouldn't an amylase stain
amylase,
be
yeah.
useful?
So the pancreatic amylases that they use in pancreatic acinar don't work as well in salivary acidic. I've tried them, but they're not as reliable. But yes, the actually just using the histochemical stain of PAS diastase is going to give you more yield than an amylase, because the amylases don't work as well in salivary. But yeah, you'll see the nice retained, really dark, chunky granules, because they are diastase resistant. So that, for me, PASD is very helpful. What else is thought to be useful in actinic? What other immunostain?
Dog1.
Yeah, dog1. So dog1 can highlight the luminal kind of border. Sometimes also the cell membranous border of the cells. So that can be helpful, but it's a little bit hard to interpret because it can be very weak at times. But if you see that kind of luminal acinar highlighting with dog1, yeah, exactly. That can be helpful. And as with other monomorphic salivary tumors, these should be P40, P63 negative. If you're debating between a secretory carcinoma, they should be S100 and mammoglobin negative. So that would be a distinguishing factor. So we got that, we got that. It's the only one left. There's one more. Oh, there's 3 more.
Number
Well,
7, yes.
Yeah, these
8,
guys.
yeah. This is nice one, very well circumscribed, encapsulated.
Mm-hmm.
And it's the tumor cells with tubular,
Mm-hmm.
trabecular
Mm-hmm.
growth pattern.
Mm-hmm.
We have peripheral palisading.
Mm-hmm.
We have kind of, very basaloid.
Mm-hmm. Mm-hmm.
And we have this basement membrane material, the
Mhm.
pink
Mm-hmm.
hyalinized stroma.
Mm-hmm.
So I would go with basal cell adenoma
Yeah.
for this case.
Yeah, absolutely. It's a really kind of characteristic case of, on low power, you might think, oh, could this be a cellular pleomorphic adenoma? And it may be, but there are a few subtle features, including this very tubulotrabecular architecture, this peripheral palisading, this hyalinized kind of globular, very eosinophilic basement membrane material. And lastly, what's sometimes discussed in basal cell adenomas, here it is this very kind of streaming spindled stromal cells in the background between the tubulotrabecular nests. These cells are strongly positive for S100, so that can be helpful. But yes, otherwise you do see these tubulotrabecular architectures. And interestingly enough, basal cell adenoma is also a biphasic type of neoplasm. So you should be able to highlight these duct-like areas with c-KIT, and then the more background palisaded areas of myoepithelial type cells with P40, P63. So those 2 stains plus the addition of S100 in this stroma is very, very nice. What else is very helpful in basal cell adenomas diagnostically? What stain?
Beta-catenin.
Beta-cat, yeah, exactly. So it should stain the nuclei of at least a subset of tumor cells in basal cell adenomas, which really doesn't occur in other salivary type neoplasms. So Christy, what is S100? What is that? Am I supposed to answer that question?
I was playing homage on to, Jeopardy. What is this?
What is S100? Yeah, it stains those cells. Maybe they have some myoepithelial phenotype, and so they have S100. I don't know, or some neurotized phenotype. I don't know, but yeah, cool. So then I think you can maybe see that where I'm getting at with the tumor right after it. Oh, very similar kind of tubulotrabecular architecture with hyalinized kind of globies in it. Carcinoma, exactly. But if you look carefully in the other field, these lobules and nests, percolate and infiltrate, and now in between your other sort of, they circumscribe your vessels. They run, along either side of normal ducts. Exactly. So this is an invasive basal cell neoplasm. So this is basal cell adenocarcinoma. You sometimes do not see beta-catenin mutations in these. So don't expect to see beta-catenin positive in these nuclei. In this case, it's very morphology driven with these nice globules, very nice trabeculae. Sometimes what are these tumors related to in the skin? Do you guys remember?
Cylindroma.
Yay, cylindroma. So these sometimes have the CYLD or the cylindroma gene mutation. The basal cell adenocarcinomas do not tend to have the beta-catenin mutations. And don't call these basal cell carcinomas like of skin. They are basal cell adenocarcinomas of salivary gland. So that would be the only caveat. And then I think this is last but not least. Yeah, I think we've seen everything else. Are salivary gland basal cell adenocarcinomas also seen in Brooks-Spieler? Not that I know of. But that's a good question. I know somebody's studying for the boards. I don't know. I don't know. You can look that up and let us know. I haven't read about it, but I haven't also been studying for boards in a while. Are you asking for answers to the test?
There's a lot of clear cells here.
Mhm.
And it's like, it looks like it's infiltrating maybe, it
Mhm.
looks like to be a minor salivary
Yep.
gland. There's a lot of
Yep.
colonization.
Mhm.
Is this a clear cell
Mhm.
or hyalinizing clear cell carcinoma?
Yeah,
possibly?
yeah. So exactly. So I mean, this is a textbook example of clear cell carcinoma, formerly known as hyalinizing clear cell carcinoma, but they got rid of the hyalinizing because it doesn't always hyalinize. And for that matter, it's not always clear. Sometimes it can be pale eosinophilic, but in its classic form, yes, it has these very water clear cells with kind of collagenous membrane material in the background. Exactly, non-clear cell carcinoma, with these kind of wrinkled nuclei. And so the two points I'll make about this is, often you can see these in minor salivary glands, just like polymorphous, right? We tend to see in minor salivary glands, especially the palate. This is also a palatal case. The two things about clear cell are what do they stain like and what are their genetics? Are we sure it's not an RCC? Yeah, we can make sure it's not an RCC by doing a squamous profile and a Pax8. Exactly. So these stain like squamous, so they have high molecular weight keratin and P40, P63. They do not have any of the other myoepithelial markers like SMA or calponin or GFAP. They do not have those, right? So they basically are isolated squamous cell markers. So if you have a carcinoma that you kind of staining like squamous, but is a little bit lower histologic grade, such as this is not a glycogenated squame, right? This is a clear cell. And yes, it has EWSR, ATF gene rearrangements, which are the same gene rearrangements that you see in clear cell carcinoma within the jaw bones, which is odontogenic clear cell carcinoma. So those two tumors are essentially identical, with the exception of one occurs in the salivary tissue and one occurs in the intraosseous tissues of the head, the jaws. So yeah. What else? Okay. Awesome. I think we did all of them a little bit over time. I apologize, but at least we didn't have to do a whole second session. So thank you guys. I'll stick around if anybody has any questions. Malignant salivary gland tumors in BSS appear to be extremely rare. Result from malignant transformation of pre-existing basal cell. So kind of, sort of. Thank you guys.